I would like
Yes.
to welcome everybody into this session. This is the month of hypertension and nephrology. And I would like to welcome you to this AHN, Africa Healthcare Network Nephrology Education Webinar. And today is series number 34. And today we'll be discussing about sodium, lifestyle, and hypertension. So it's a continuation of last week's presentation from Professor Tobe. So Professor Tobe is a professor of medicine, University of Toronto and Northern Ontario School of Medicine. He's a postgraduate fellowship director in adult nephrology, University of Toronto. He's also a co-chair of the Canadian Cardiovascular Harmonized National Guideline Endeavour, or C-Change. And those who just joined, he explained about what is C-Change, and you can go to the cchangeguidelines.com, and then you can register, and then you'll see all the education presentations and topics for you to learn. Professor Tobe is in a board of director, American Society of Hypertension, a specialist program. He has had continuous peer review funding for 25 years and has received more teaching awards and other career distinctions. Professor Tobe has published over 150 peer-reviewed articles and has led and participated in peer-reviewed and investigator-initiated multi-centered international research collaborations. So, Professor Tobe, thank you very much for joining, and welcome to continue the presentation.
Thank you so much. And it's a real honor and a pleasure to be here, especially with Lloyd and yourself. We will make this session as interactive as possible. Please jump in, and please feel free, if you're able, to use your chat function. Let me just open mine up so I can monitor it. There it goes. We'll share the screen. Today's module is shorter than last week's. And it will, we're talking about sodium today, something that's near and dear to the hearts of nephrologists. Okay, thought I had it back to the beginning. I like the chat to be in front of me, so then I can, we can monitor, there it is, it was hiding. We can monitor questions. Very good. All right, but I lost that. One more time, swap the presenters, display. Hypertension, sodium, and lifestyle. And thanks to Luc Trudeau, who put this case together. And we have a scientific planning committee here, which is largely primary care. And Deb Reed is from the Dietitians of Canada. And I work as the series editor to make sure all the modules have the same look and feel to them. And so the material has been reviewed by this committee, and I still do some speaking for some industry and research support, as was kindly mentioned. And often we'll have various companies sponsor only online as patient and work through, and it should be as interactive as possible. And we'll get your interactivity both from unmuting and come on to have discussion, as well as using the chat function. And this study, this module is about Lavani, who is a 56-year-old woman from India who presents to your office, and she has worsening hypertension. So we're going to talk about our Canadian recommendations for the management of hypertension, talking about sodium and lifestyle, and explain the relationship between sodium and hypertension, and hopefully how to prevent the onset of hypertension, or at least delay it, with improved health behaviors. We talk about how some foods can have more sodium than you expect. So please use the chat function and tell me about your greatest challenge as a healthcare provider in managing patients with hypertension when it comes to sodium restriction. and limiting sodium in your patient's diet. Please go ahead and put your thoughts into the chat function. Yeah, following our advice. It's not easy to do. Diet and weed is so much a part of who we are. It's part of our culture, our heritage, and it adds immensely to our quality of life. And when we say, I'm the doctor and I want you to change what you eat and how you eat it, patients will nod politely and say yes, but getting them to change their behavior is really challenging. And today we'll go through some of the principles, physiology of this, but when it comes to changing our patient's behavior, unless we have specific training and understand the culture of our patients, I think we'll need additional help. Kasiki was the other town. So we were in Kasiki or Lambo, I can't remember which one, for the Dream Global study. And we had we were doing a focus group. So we had invited people to come from the local community to have a blood pressure measurement, which we performed, and to answer some questions about blood pressure management so we can understand how best to implement a blood pressure control project. And we had provided a meal, a nice warm meal, some really yummy food. And about half of our participants were taking the food and putting it into containers and putting it into backpacks and bags. And I asked why through a translator, and the patient said, there's more food right here that you're giving me than we would normally eat in a week, particularly this kind of food. And I'm bringing it home for my children and my grandchildren. And I was, typical Western. I was very, very surprised. And but it makes sense, and it's very important to understand how our patients are living, and to walk in their shoes, to be able to understand best the challenge of helping them to change their behaviors. So I am very humble about this, and I feel if we're going to be successful, that we need to we need to work if we don't have that connection ourselves with someone who has a connection with our patients, who can talk to them in their language and understands their culture. And, often a dietitian is, if available, we work very closely with the community, the community health worker, who was invaluable in terms of translating and explaining our plans for reducing sodium in the diet to our patients. So yes, talking to the patient's spouse is extremely important. Understanding who's doing the cooking and the food procurement. Education is really important. And we have a pediatric hypertension expert here, and there was a study done in at the same. There are 14 studies commissioned. Dream Global was one of them. There were 2 or 3 that took place in China. One of them with Dr. He, and she went into the public schools and trained children in public school. I think they were grade 6 students or grade 7 students, how to eat properly, and with the goal of lowering sodium in the diet. And then they did 24-hour urine tests on the children and their parents, and they gave them literature to bring home to their parents, and it worked. The children ate less sodium, and their parents also reduced their sodium intake. I don't know how long that lasted for. And there seemed to be a reduction of blood pressure. But what are your thoughts about? Is it feasible to talk to children and to get them on side to help lower sodium and to prevent hypertension and progressive kidney disease in the next generation.
It's an interesting talk. That in schools, I presented that study to the same audience, and we went back and did a talk. Actually, surprisingly enough, younger children seem to be much more receptive to taking up the challenge than adults. And I think if we target schools, we will make a little dent. I'm not saying it's going to be it's going to last for a while, long time, but definitely in our cohort, it did make a difference and the blood pressures dropped. Okay?
Health
so children
should
are
be
receptive.
Yes, health should be a subject in the school like physics, chemistry, and mathematics. And that will save
Absolutely.
a lot to the nation as well. You know, that the children are ingrained with these ideas of low salt, exercise, diet. That's when we need to train them rather than when they come into the problem. So it has to be a subject in, a lot of aspects of health can be taught in school and as a subject, and they go through exams as well. It's more important than all subjects that we do. So it will have a lot of impact in the long run.
I'll tell you a quick anecdote. Oh, go ahead. Sorry, go ahead.
Sorry. I fully support Lloyd on that. The other thing we should target, and this is more difficult, is the type of things that are sold at school in tuck shops. If you go to any school, whether it be a private school or a public school, and you just have to go to the tuck shop, what are they selling? They're selling the crisps, which are full of salt. They're selling all these French fries, everything else that is packed with salt or preserved foods, like pies, etc. Apart from, of course, the sweets and chocolates and cool drinks are full of sugar. You know what I mean? So the thing is, it has to be a whole paradigm shift in the way that we are approaching diet and education in schools. And I think educationists need to take that up. Okay. Thanks.
Thank you for that. Two quick anecdotes that come. One comes from the Dream Global study. Part of our study was in Northern Canada. Mm-hmm. And we went to a very, very remote community called the Klavik, where the Mackenzie River hits the Arctic Ocean. Look at it on your map. You won't believe that people actually live that far north. Wow. It's so far north that their septic tanks under their homes freeze if you leave them more than 48 hours. So they have a truck that comes in the winter to pump out the septic tanks. Anyway, it's too cold. People shouldn't be living there if they have to have that septic tank pump out their tanks. Septic truck come and pump them out every day. Anyway, that's not what I was. It's just an example of how remote it is. But when we started our study, our goal was to reduce sodium, to substitute some foods in the grocery store to allow them to do that. Fast food kiosk that had just been installed six months earlier with French fries, fried chicken, pizzas, and that kind of food. And we said, is there any chance of making that go away or replacing it with healthy foods? And so the town leader was the mayor, and it was very clear that if he passed policy to get rid of that fast food, that he would no longer be the mayor. And he might no longer be welcome in that town. So it's quite challenging. The other insight is my daughter, when she was also in grade 3 or 4, brought me to school for show and tell. And I brought with me in those days we had a public translation of our hypertension guidelines, 2 or 3 pages long. And I brought it and I gave it to the students in the class. And I said, bring these home for your parents. Well, it's interesting. The students actually read them. And as you know, with your children, over the course of the next year, I had an opportunity to bump into them in the parks, at baseball games, and various activities in the community. And they would recognize me, and they would tell me that they had read the recommendations and they had acted on them. And these young children were much more adherent and interested than my patients ever were. No exact amounts of salt packages can be used by your patients. Instead, they depend on just estimations. Yes, very difficult. Very difficult. We have to do our best. Okay, let's jump into it. Great feedback. So risk factors for hypertension, high sodium intake really leads the way, and from a population health perspective is very important. Obesity goes along with a high dietary sodium intake, as well alcohol intake for a proportion of our patients. Sedentary lifestyle, which is a real problem in the West. Smoking is a problem everywhere in the world, and malnutrition and the inability to get fresh fruits and vegetables that are healthy, that are high in potassium, and dairy intake, particularly for children, is also helpful for lowering blood pressure. The potassium, which I don't think we'll come back to, a diet that's high in potassium, potassium acts in the nephron through a series of these Wnt kinases, WIN, without potassium, these kinases, through a double negative inhibition, but it leads to sodium excretion. So potassium actually has a diuretic-like effect. Now, we're not talking about patients with kidney disease, right? That's poison for our patients with CKD, but for everyone else, a diet that's high in potassium is very helpful for excreting sodium. And I know it looks like a bit of a swarm of bees, but the relationship between dietary salt intake and blood pressure is there. And on the x-axis, we have the amount of sodium excreted in 24 hours, and good sodium studies are done with 24-hour urines. On the y-axis is the systolic blood pressure, and there is quite a reasonable relationship between them. Hypertension, as you know, is a major risk factor for stroke, for heart disease, heart failure, kidney failure, and hypertension is really keeping our dialysis units busy. And if we could control blood pressure, we would really reduce the number of patients ending up on dialysis. And Lloyd, you recall one of our analyses from the DREAM Global study was that even over a couple of years, we reduced the absolute number of patients who were starting on dialysis and increased the number of patients who had chronic kidney disease. So that those patients with CKD weren't progressing on to dialysis. So you can see the results quite quickly. Dementia and prevents dementia, and that was shown in the SPRINT study, the SPRINT Mind. Atrial fibrillation, and for our male patients, hypertension is a major contributor to erectile dysfunction. Sorry, Lloyd, you were saying. Hypertension in Canada is a leading reason for visits to the office, and if we can bring blood pressure under control and help to prevent hypertension, we can really reduce the impact on the healthcare system. So our patient, Lavani, young woman, 56, and she was born in India, living in Canada, married with 2 children, and she eats and dresses in a traditional fashion. So for Canadians, we would think, oh, well, traditional Indian diet, vegetarian, must be super healthy. You know, so that couldn't possibly be contributing to her hypertension. And her blood pressure at home is high. It ranges from 140 to 154, over 88 to 94. And her average pressure in the office indeed is high. It's almost 160 over 100. She's feeling well, and she doesn't have any symptoms of sleep apnea. She's able to do all her activities of daily living, and her weight has been stable. She's been hypertensive for the last 5 years, and she's been on the same medications. She doesn't do any particular physical activity, but when she walks up and down stairs, she doesn't feel short of breath. So probing for diastolic dysfunction. and she gets some aches and pains when she's standing for a long time, and she had had her gallbladder out earlier. Her father had hypertension and died from heart failure at age 60. Mother had a stroke at age 76, also hypertension, and no diabetes or dyslipidemia in the family. So she gets her hypertension from both parents. Her medications are good medications. Maybe we would argue that she's on a short-acting thiazide diuretic, and she should be on a long-acting thiazide diuretic. She takes ibuprofen for her pain, and she likes her traditional foods: rock salt, Indian pickles, gooseberries. Lloyd, do you want to comment on these foods? I'm no expert.
Indian pickles, a lot of salt. Gooseberries is wrapped with salt. Rock salt is potassium, so you're getting a lot of potassium. So that's it. The ibuprofen, again, I don't think is really good for her. So that's about it. So it's a lot of salt. It's a lot of salt.
Now, are these part of your diet, for example, or were they part of your family's diet in the past?
In the past, yes. In the past, yes. Sometimes even now, certain families, yes.
On exam, I forgot. Would someone like, oh, you know what? Just because of bandwidth, well, I'll just go ahead. Her waist circumference 86 centimeters. Her BMI is 25. Lloyd, any comments on a BMI of 25 for an Indian woman?
It may be a little bit on the high side, probably for her, for an Indian woman.
See, from
upper limit of normal.
Okay, and the rest of her exam is normal. Okay, so what are we going to do for Levani? How are we going to manage her? Are we going to increase her ramipril, adjust her dose of hydrochloride, or give her a long-acting diuretic? Do both, or are we going to chase her lifestyle? And one or more letters of your favorite treatment plan here. Thank you, Jacqueline. Agenda, excellent. Quick off the mark. Okay, well, the module is about lifestyle, isn't it? Okay, sure. So we could increase her ramipril, and we could increase the thiazide, or put her on a long-acting thiazide, or we could do both. And that's complementary.
Sheldon, do you mind if I just make a comment, please?
Please, please.
So we all chose lifestyle changes, and I think that was the right answer you were looking for, right? But let me tell you, as an Indian, and especially Indian women, I don't know if Lloyd has the same experience in his country, but in South Africa, many of them are now working, etc., and adapting a westernized lifestyle. But with the lady that you are describing in traditional dress, etc., for her to change her diet and to change her lifestyle and do more exercise is like, asking her to go to the moon and back. You understand? I mean, it's going to be very difficult. She's got. So we have to very seriously think about not just telling her how to do what to do, but exactly how she's going to do it. And that's the challenge that we have to face. You understand? I mean, they're telling our patients, you must change your lifestyle, exercise more, eat less salt. It's easy to do. How are they going to do it? That's the big problem. Because remember, she has to cater for her whole family and probably the extended family as well. And it's a major challenge for her. See?
Agreed. And as healthcare providers, we need to know what to do, and we need to know why. And that gives us the confidence that when we're asking our patients to make these changes, that they see that we are really serious, and they feel that it's very important to us. And that's an important component, but it only goes so far, as you point out. And then, we need to do a lot of other approaches to help our patients to change their behaviors. Sorry, I couldn't hear. Oh, maybe it was just some noise. Okay, so when we're talking about her lifestyle, we want to review the sodium content of the traditional diet so we can understand what is actually in her diet. And we know that limiting sodium will reduce the blood pressure in itself, and it will make the medications more effective. As we reviewed last week, there's a sub-analysis of the ID&T and renal studies. Those studies were using ARBs, in patients with type 2 diabetes to prevent the onset of diabetic nephropathy. And patients who had a diet high in sodium, it was much less effective. Talk about the benefits of physical activity and remind our patients who have hypertension or progressive chronic kidney disease about avoiding non-steroidal anti-inflammatories and particularly using them on a regular basis and trying to get them to use acetaminophen, which is safer. So let's review our health behaviors. So reducing sodium intake to around 2,000 milligrams per day, 2,200 is healthy. Now, lowering sodium intake too much is also not good. We need to have a certain amount of sodium in our diet, but moderation is important for everything. And in fact, Salim Yusuf talks about his insights from diet from the large clinical studies that he's done around the world, and points out that very few people have the ability to lower sodium down to targets like 1,500 milligrams per day because of fast foods and processed foods and the way food is made. It's really not in our control to lower sodium too much. But too much sodium, of course, is no good. And the ability to, we all have the ability to avoid excessive salt in the diet. Regular physical activity, new exercise recommendations coming out, but they all say 150 minutes of moderate to vigorous activity per week is very helpful. Of course, if a patient has disabilities and has difficulty or is already sedentary, that may be really difficult to do. So for our patients who are sedentary, just going from being sedentary to doing anything gives a huge benefit. And that's where the greatest benefit comes for those patients. Then if they can go from doing anything to targeting that 150 minutes of moderate to vigorous activity per week, will give them additional benefit. But if we push 150 minutes right away, someone who's sedentary might feel that it's too much for them. And for our patients who have disabilities, they may not be able to walk briskly 150 minutes a week. They may only be able to shuffle along slowly. That's fine. They just need to do it for a longer period of time. Thank you, Elliot. I would do both and reduce their antihypertensives once we get to target. Practically, diet alone is difficult for her, for the patient to bring down the blood pressure, and the long wait may lead to complications. Sure. So we can take both approaches. Let's use adjust her medication to bring her blood pressure to target. And then as she brings her sodium intake online, she's going to complain about being hypotensive, or we may see her and then adjust down her medications. Alcohol increases blood pressure, mechanism unknown, but greater than 2 drinks per day will increase blood pressure. And our target is for men, less than 14 alcohol equivalents per day. For example, a glass of wine or a bottle of beer, and less than 9 for women. Keeping ourselves trim and waist circumference. These are European numbers, and of course, tobacco free. Then we have this acronym for physical activity: FIT, 4 to 7 days per week, moderate intensity, 30 to 60 minutes each time. So 30 minutes a day, 5 days a week, 150 minutes. And there's lots of different activities. Walking, of course, is what most of our patients can do. But for those who with disabilities, of course, it's more challenging. So, global cardiovascular risk. Now, our patients with hypertension, in Canada, 9 out of 10 of those patients will have other cardiovascular risks. And of interest, the more cardiovascular risk they have, the more likely their blood pressure is to be under control, but the less likely those other risk factors are to be controlled. Obesity, smoking, dyslipidemia, blood sugar, and so on. So think about hypertension as a probe for your patient that something else is going on. And I'm sure Rajendra, is when you find hypertension in children, right, the majority, my understanding of those children are going to have chronic kidney disease. So it's like the hypertension acts as a finder for other illnesses that we need to deal with.
Yeah, except that the spectrum is now changing. We're seeing more primary hypertension in children than we've ever seen before, exactly for the reasons that we are saying. They're eating fast foods, they're taking high salt, they are not exercising, they're only on the phones and the laptops. So we are seeing the same thing that you are seeing in adults. No more is it that we are seeing hypertension purely due to kidney disease. That's becoming the second cause now.
Unbelievable.
Yeah, but it's true.
Okay, here's Lavani's numbers. Her blood sugar is okay. Kidney function is okay. Her potassium is nice and normal. Hemoglobin's okay. And her cholesterol's not surprising. She's her triglycerides are on the upper limit of normal. And here's her typical diet. Rajendra, do you want to comment on her diet?
That's the typical Indian diet that you see. Eating puri is like pita bread, but it's fried, so it's high in fat. Okay, halwa is a sweetened kind of pudding. Okay, so it's got more sugar, no salt, so not that. Paneer is basically cheese sandwich. And canned fish, of course, got a high salt content. So you got two things with high salt content there already. And also the dinner is chicken tikka, which is high salt. Gulab jamun is basically a sweetened kind of pudding. Once again, it's dipped in syrup. Okay, so that's got no salt. And basil tea is good. Okay, it's good antioxidants. But definitely chicken tikka has got a lot of salt. And basmati rice, they also add salt to it. So you got two things that got high salt content. Lloyd, is there anything else that I missed out?
No, this is like a Canadian Indian diet. Indian diet.
Yeah, that's a typical Canadian Indian diet. I lived in Canada, by the way, Sheldon, for a year. So I know a lot about it. In Toronto, I studied at the hospital for sick children.
Very nice. Reading this diet makes me hungry. And as you both know, Toronto has some of the best, has really excellent Indian cuisine. Yes. And we're very blessed that way. So when you add it all up to see what she's eating in a typical day, poor Lavani is eating 5,000 milligrams a day of sodium.
Yeah.
And so she's even from a Canadian standard, she's on a high sodium diet. Typical diets in Canada are 3,000 to 4,000 milligrams of sodium. So it's hard to believe from her dinner. And there's some more details here. That her sodium intake could be so high. In Canada, the #1 source of sodium is bread. And what about in East Africa? What do you know what the leading source of sodium is? Or is it salt that's eaten at dinner time?
Dr. Gina, anybody?
Yeah, so the problem is in East Africa, we don't know the content, salt content of the food that we are taking most of the time. Probably it can be bread, but normally we eat these normal traditional foods for majority of the population. And like cassava, yeah, cassava, potatoes, sweet potatoes, and those kind of things, and of which we don't know the content, the salt content of it. So it is difficult to tell exactly how much can one is taking in terms of salt.
I had a picture. I forgot all about this, but when we were in Moshi at the Nakamat, the grocery store, there's a bag of crisps of potato chips, and it was called Simply Salty. And they were proudly saying it on the front of the bag that exactly what was in it.
Yeah, but then, Prof, only a few people can afford to go to the supermarket and buy foods. Majority of the population, for example, in Tanzania, they normally eat traditional food. And if in Moshi, for example, yes, they like the lifestyle is higher compared to other parts of this country, so they might be eating differently from the rest of the.
Yes, and I noticed population the Nakamat was quite limited.
I'm just saying I'm agreeing with Makobe about the Moshi being a little bit different from the rest, but I also find that in terms of the spices and how to make food more tasty, yeah, the number one ingredient is salt. So there's still a lot of consumption of salt.
Yes.
A question.
Moments that I've spent with you, most precious moments.
Eating outside.
I don't expect anything more from you. It is the best gift that you have.
Peace, do you have a
No, I just wanted to give a comment. From the Ugandan point of view, I find that if usually if I'm talking to fairly like elderly patients, usually elderly patients are a bit more strict with Ugandan diet, and the Ugandan diet generally doesn't have that much salt. So many of my patients would actually end up with low salt levels, because most of the time most of the older patients don't like bread, so they won't really eat bread. It's more of the younger patients who eat that. And if they eat like the usual rice, beans, matoke, that's actually high in potassium. So it actually helps with their sodium. So people who are really strict with the Ugandan diet, usually salt is not very high on their, well, hypernatremia is not really, well, I think, yeah, I always advise, like, people are strict to the African diets, Ugandan diet, then so high salt sometimes is not really the cause of the hypertension. Thank you.
Thank you. We worked with students to help us do our focus groups when we were in Tanzania, and we had high school students who came and volunteered with us, and to help us with translation, and we trained them to be qualitative researchers. We brought my colleague Marion Marr, who did that, and we had questions that and statements that we're sending out on text messages, and we were translating them to Swahili. And one of the text messages was according to our guideline, which was it's important to eat a healthy diet full of fresh fruits and vegetables 3 times a day. And getting to the point of knowing what our patients can and cannot afford to eat. And I'll never forget the body language. We had about a dozen students. The body language changed. They became very quiet, looked down at their feet, wouldn't make eye contact. And Dr. Marr said to them, "Oh, okay, what happened here? What was it, that made everybody so uncomfortable?" And so then they told us, they said, that statement is assuming that the people we're talking to can afford to eat 3 meals a day full of fresh fruits and vegetables. So from the Western perspective, that was a huge shock, and really reinforces the message that we need to know and understand the lifestyle and the socioeconomic status of our patients. I'll never forget that. So Canadians eat a lot of salt, as does everybody else pretty much. And in India, there's lots of salt intake in India as well, and lots of hypertension in India. So what is our measures of sodium? 1 teaspoon of salt is 2,000 milligrams, and that's 87 millimoles. And it's about 5 grams of salt. Most of our salt, at least in Canada, comes from fast foods and processed foods, and only 10% in this country comes from adding it after cooking or in the cooking. If we lower salt in if we lower sodium intake, in hypertensives, we lower blood pressure by about 5/3 millimeters of mercury, and in normotensives by about 1 millimeter. But across an entire population, that's really important. And in Kenya, there's a great difference between the main towns and rural environment, and the town population would typically eat processed foods. The DASH diet is the best study really in sodium restriction that really demonstrated the improvement in blood pressure control. And there's a very dramatic reduction of blood pressure. Now, my patients tell me, but doctor, I'm not eating salt, I'm having kosher salt or sea salt. But salt is salt is salt. And here's our information from our Canadian food guide. Of course, this is for Canada, and it doesn't necessarily translate to other parts of the world. But the principle is more fruits and vegetables, more potassium intake, fiber, less meat proteins, and that will help. And to reduce dietary sodium, we recommend if our patients are buying bags or cans in the store, if they're marked with the nutritional value of what's in them, we say try to have 5% or less of the recommended daily value of sodium. So let's say a bottle of V8 juice. I don't know if there's V8 tomato juice that's available on your shelves, but a typical serving of that will have 17% of the recommended daily value amount of sodium, but the low sodium version of V8 has less than 5%, so, which is okay. And for home cooked meals, it's not that we want patients to use no salt, although we say that here, but we want them not to have a heavy hand with sodium, and then not to add it again at the table later on. But if we are very harsh about sodium restriction, then our patients aren't going to follow our instructions and may sneak off to their friends or somewhere else to find some good food. In Tanzania, especially big cities like Dar es Salaam, being there, you are at risk of eating fast foods like chips, fried potatoes, and meat with lots of cured meats, get you into trouble all the time. And yeah, what if sodium is used to preserve the food? What about the alternatives? So I would argue that if our patients require sodium to preserve the food, chances are they're going to be quite active and walking a lot, and their health behaviors will be improved in other ways. And we can ask them to rinse the food before they're eating it, and to dust off the sodium, or to let the food sit in water for a while to try to get the, like if they're salted cod, for example, they can let it sit in pots of water to get the salt out of it before they're using it to cook. These things at the table, ketchup is one of the worst offenders when it comes to both sodium and too much sugar in the food. And other sauces, just read the labels and be careful. Restaurants, fast food places are just salt. They're just loaded up with sodium. get our patients into trouble. And the people who design that food know exactly what they're doing, because as humans, we want to consume a diet that's high in salt. We want that high fat. We're just genetically we're genetically designed to want to consume those foods. And the food industry knows that and caters to us. So we're fighting a very, very difficult battle. So how does excess salt increase blood pressure, increase salt, increase volume in the body? And as the increased salt gets into our cells, the potassium-sodium ratio changes, leading to vasoconstriction, increasing our peripheral vascular resistance. That increases blood pressure. And all of our patients with chronic kidney disease all have a sodium component to their hypertension. Lowering sodium intake, using diuretics in those patients is very helpful. And over time, if we eat too much sodium, our kidneys adapt to that and just keep extra sodium in the body. Increased sodium in the diet contributes to increased peripheral vascular resistance. People who are genetically predisposed, like our patient here, Lavani, to develop hypertension, if they're eating a diet high in sodium, will develop hypertension earlier. If we can get them to restrict their diet and get them on a lower sodium diet pathway, they will develop hypertension much later on and have less exposure to hypertension in their lifetime. Of course, improving the endothelial function. We've talked about how hypertension impacts on all the other target organs, everywhere that gets blood supply. Of course, near dear to to us is a renal failure. Patients with chronic kidney disease.
Robert, pole bwana. Aisha mimi naweza kuvimba lini?
We'll have progression. And can sodium intake cause organ damage? And just for time, we'll just go through this. And of course, it can. And it promotes peripheral vascular disease, left ventricular hypertrophy, and of course, chronic kidney disease, increases the risk of kidney stones. And in Canada, of course, bread is the #1 source of sodium in adults, cheese for children. Now, Lavani gets counseling about reducing her sodium, avoiding the canned foods, limiting her sauce and condiment intake. And after 3 weeks, her blood pressure nicely comes under control. Sweating off the salt is effective, yes, but we'd have to spend our whole time. Well, mind you, here in this cold country, in Canada, in a sauna, but I guess in Africa.
So Sheldon, my questions are actually two parts. That one of the mechanisms of hypertension involve trapping sodium in the interstitium. So if you're only removing it through the intravascular area, and how much effective is just sweating it off, or diuretics, or there's still an effect of the interstitial trapped sodium?
So I don't think we know the official answer, but my belief is that it's important. And I think this is why we are physiologically in love with sodium, that we have a hard time refusing food that is high in salt, is because our physiology is that if we're working in an environment where we're sweating a lot and losing volume because of the sweating, that we need to replace that salt. So I believe that we could conduct an experiment where we make our patients sweat profusely, and that would likely be effective in lowering your blood pressure. I don't think it's practical though, but I do believe that the physiology is correct, that if patients we were able to make them sweat off that salt, that it would likely be good for them, but I just don't think it's practical. So Lavani is walking now regularly. She's continued her dietary changes. Her weight is down a bit. Her blood pressure in clinic is now, this is with an old blood pressure device. It's 140/88. But we'd like to see it a little lower. We'd like to see it less than 135/85. with an office automated measure. We'll talk about that next week, I guess. The rest of her exam is normal. And these are the kind of blood pressure reductions we can get when we reduce sodium in the diet. And similar to these others. Now, the changes of blood pressure lowering with these health behaviors change are additive, but the more we try to load onto our patients, the less likely we are to be successful in getting our patients to follow all of these practices. Whether we can take 3,000 milligrams of salt and use a thiazide diuretic to increase excretion so that the balance remains the same, I don't think so. Because that sodium is going to interfere, it's going to get into some of the cells and change the balance in some cells, the sodium-potassium balance, lead to some vascular resistance. So I think over time, over years, that wouldn't be a good response. We know that hypertensive patients, if we control their blood pressure right away with diuretics, they do better than patients without blood pressure control, but they still have a higher risk of patients without hypertension. Sodium loss in sweat is lower than assumed. True, like you'd have to sweat an awful lot to become hypotensive. Yeah, we tend to be more more sedentary than we believe. The DASH diet was enormously effective, 16/10 millimeter reduction versus 3.4, 4/4 in patients with usual care. DASH diet is not an easy diet to promote, and there's 1,000 milligrams a day difference in sodium intake in the DASH group. So lowering, there are not great studies for other than DASH for lowering sodium. And if in Canada we could reduce the sodium in the diet, there'd be a whole lot fewer Canadians with hypertension. But again, it's fighting a very difficult battle because the entire food industry is lined up against us, promoting diets that are full of salt. And even a small reduction of blood pressure leads to a large reduction in cardiovascular events, great cost savings. So our target is targeting a sodium intake of around 2,000 milligrams a day, restricting alcohol intake, increasing physical activity. And I'll just put this up. And if we can get Lavanya to change her diet, then it will be easier for her to control her blood pressure with fewer medications. And the question is, how do you get her to do that? I think putting her in a sweat box and sweating it out of her is not going to work. I'm interested in your thoughts. And for those of you who found some successes in your practice, please share them with us.
Thank you, Prof. Professor Tobe, that was great presentation. So there is one chart which says if you increase thiazide diuretics, then that will help in sodium excretion, and then that will be helpful. What's your comment on that?
Just that patients who, if we cause hypertension in patients, a hypertensive patient, when we treat them with antihypertensives, we lower the risk, but it never goes back down to normal again. So giving patients enough salt in their diet that predisposes to hypertension, that makes them get hypertension at a younger age, preventing it from happening is much better than letting it happen and then treating it afterward. So yeah, I would doing both, as was mentioned right at the beginning, lowering the sodium intake and lowering blood pressure with diuretics and other medications as needed. That's the most effective. But when we're talking about preventing hypertension from occurring with a low sodium diet, or reducing and preventing a high sodium diet is really, really important. And from a population health perspective, is very effective.
You know, when we come to exercise, and I was once doing a talk on the radio, and someone asked me, but if you have a busy day, how are you going to exercise more than you're already doing because your day is so full? It's very difficult to squeeze that in. And I'll just want to do some of the things that I do, for instance. When I go to hospitals, I park as far away from the entrance as possible, so it forces me to walk the distance. Try not to use the elevators, try and use the stairs rather than, even if you're going up to the 4th floor, 5th floor, 9th floor. So you have to walk up that and forces you to exercise because you still have to get to your destination. And the other thing is, even when you go to shopping malls, etc., try not to park at the nearest entrance to where you're going to, park at the furthest entrance. So you're forced to walk that distance to the mall. It might encourage you to buy more, but that's the downside of it. So I think there are some practical ways, which don't confine patients to doing exercise like what we want to do, because then it becomes difficult then to build it into the day because they say they are so busy. You know what I mean? So we just build it into the normal routine. And of course, things like eating fruit and vegetables, it's something that people are not used to. So I tell the patients that keep it with you. If you're feeling a bit peckish, just eat a fruit. You know what I mean? Rather than having to eat pickle or some other thing that's got a high salt. And it helps. It does help in some ways. But like I said, kids are much more receptive than adults. So I have a little easier task in that way. See?
Rajendra, thank you for that. I agree completely. What I add now to that, and I agree 100%, for the exercise, for taking the stairs, I tell my patients, COVID doesn't live on the stairwells. It's living in the elevators. Get out of the elevators, take the stairs.
Exactly. Exactly. Thanks. Okay.
So I just wanted to know, when you mentioned exercise, you actually said running, walking. What about weightlifting? Those who are going to the gym and building muscles and weightlifting, does it really have anything to do with the reduction of high blood pressure?
It does, actually. So resistance exercise, we know for a fact that it does not increase blood pressure on the long term. While someone is lifting a heavy weight, and I've got a good anecdote, the blood pressure is higher, but after the resistance exercise, it does not lead to permanent hypertension. So we can safely recommend resistance exercise for our patients. I'm not aware of any data that shows that it leads to long-term blood pressure lowering because it's so confounded. People who do resistance exercise also tend to do cardiovascular type exercise as well. My anecdote is that one of my favorite studies is a study of art lines in Olympic type weightlifters lifting weights, and their blood pressure hit 300 millimeters during the heavy weightlifting. And for my patients who are afraid of those spikes in blood pressure they get when they're doing home readings, and when they're having a fight with their spouse or their kids are aggravating them or they're in pain, and they see that their blood pressure is 160 or 170, I remind them about that we're designed to have high blood pressure for short periods of time. It's just the average blood pressure that is harmful.
Thank you. Thank you, Bill. So I think you have gone 10 more minutes. Maybe the last question, how does not drinking milk is a risk factor of hypertension?
I think that, I don't know the answer 100%. I believe that it's the potassium content of the milk. That's my belief. In cross-sectional surveys, people who are eating less dairy, there is more hypertension. And that data, I think, has is falling to the wayside. And in the most recent Canada's Food Guide, promoting dairy has really fallen back now from what it was. But so I think that it was the potassium content in milk and cheese that was leading to the lower blood pressure. But I can't tell you for sure.
All right, thank you, Professor Tobe. It was really very, very exciting and very educative talk. Thank you very much, Prof. We really appreciate you, your time and your energy and everything that you have put towards this presentation. And I think every one of us benefited a lot from you. So we have come to the end of our presentation. So thank you very much, Prof. Dr. Lloyd, if you have any comment or before I allow Professor Tobe to leave.
It's just that we have one more talk from Dr. Tobe, the heart in CKD and concerns to the nephrologist. This is again part of the CHEP Plus program that is actually coming up. And so that will be next week. Thank you, Dr. Tobe. Thank you for the wonderful talk and very, very informative, the slides as well. Thank you very much.
Thank you. And thank you for the great feedback and the great engagement with everybody. That's really, really enjoyable.